and it will stay there and build up and up and up. Therefore, will the fluid make the blood pressure go up or go down? It's going to go up. Okay, real quick, give me 4 examples of isotonic solutions. Did I hear you say normal saline, lactated ringers, D5W, and D5/4% normal saline? Now, when I think of isotonic solutions, the first 2 things that come to mind are normal saline and LR, but D5W and D5/4 normal saline are also isotonic solutions. Some uses are the client who has lost fluids, whether through nausea, vomiting, burn, sweating, hemorrhage, or trauma. On your handout, it also says normal saline is the basic solution when you're administering blood. Now look at the alert. Do not use isotonic solutions in clients with hypertension, cardiac disease, or renal disease. These solutions can cause fluid volume excess or hypertension, hypernatremia, fluid volume excess, hypertension, or hypernatremia. Now, let's say you're asked to get a bag of normal saline. What was the number on that bag of fluid? 0.9. Think about it. Think about what you're about to do. You're about to put 0.9% fluid in the client's vascular space. So if I could put a number on your body fluid and my body fluid, what would it be? 0.9%, yes, because we are isotonic. We have fluid in certain places and it stays there. It has a specific purpose in those places. For instance, we have fluid in our brain cells and it stays there. We have fluid in our liver. The fluid stays there. Our blood is in our vascular space and it is staying there because we are isotonic. As long as you are putting fluid in this vascular space that is exactly like our own body fluid, you're not going to see the switching and swapping of the fluid in and out of the vascular space because everything is equal. So when you put isotonic solution in the vascular space, it builds up and up and up. Okay, the vascular volume is going up. To get the switching and swapping of fluid in and out of the vascular space, you have to put something in the body that is different from your own actual body fluids. That is why we have hypo and hypertonic solutions. Different solutions are needed for different kinds of problems. Now, if I had to pick my absolute favorite shock solution, it's going to be lactated ringers because that is the one that has more electrolytes. Another word NCLEX likes to use for isotonic solution is balanced solutions. Now let's talk a little bit about hypotonic solutions. Read with me in your handout. Hypotonic solutions. These solutions go into the vascular space and then shift out into the cells to replace cellular fluid. They rehydrate, but they do not cause hypertension. Okay? They do not cause hypertension. These solutions, they go in, they hang out, and they rehydrate. Then they move into the cell. They are hydrating solutions, but these will not drive up your blood pressure because they don't stay in the vascular space. Some examples of hypotonic solutions are D2.5W, half normal saline, and 0.33% normal saline. Again, they are D2.5W, half normal saline, and 0.33% normal saline. Now, when would we use these? Well, if the client has hypertension, renal, or cardiac disease and needs fluid replacement because of nausea, vomiting, burns, hemorrhage, etc. They are also used for dilution when a client has a hypernatremia and for cellular dehydration. So let's say you have a client with vomiting and diarrhea with a blood pressure of 160/98. If you give them isotonic fluids, you are going to increase their blood pressure and possibly cause an MI, a myocardial infarction. So these are situations when you will use a hypotonic solution. So let's look at our alert. Watch for cellular edema because this fluid is moving out to the cells, which could lead to fluid volume deficit and decreased blood pressure as well. Now, last one, hypertonic solutions. What I want to be sure you understand is when you see the word hypertonic, think packed with particles, okay? Packed with particles. And we're going to talk about more about that in just a moment. But read with me in your handout. Hypertonic solutions are your volume expanders that will draw fluid into your vascular space. Okay, it draws fluid into the vascular space from the cell. Comes from the cell. Some examples of hypertonic solutions are D10W, 3% normal saline, 5% normal saline, D5LR, D5 half normal saline, D5 normal saline, TPN. Okay, TPN is your most common one, and also albumin. You can add electrolytes or glucose to about any isotonic or hypotonic solution and make them hypertonic. Okay? You remember packed with particles? Yes. So if I'm giving a client a magnesium sulfate infusion, I am giving them my hypertonic solution. And I had better watch out for what? Fluid volume excess and pulmonary edema. Okay, let's talk about the uses. The client who has hyponatremia or has shifted large amounts of vascular volume to a third space, such as a severe edema, burns, or ascites. A hypertonic solution will return the fluid volume to the vascular space. Now look at the alert in your handout. Watch for fluid volume excess, okay? Watch for fluid volume excess. The clients may need very close monitoring in an ICU setting with frequent monitoring of their blood pressure, their pulse, and CVP, especially if they are receiving 3% or 5% normal saline. All right, guys, we are done with our Quickie IV fluid lecture, and the next topic we are going to discuss is my favorite, electrolytes. The first ones we are going to talk about is magnesium and calcium. The first thing I want you to do on the top of your handout is write down, they act like sedatives. Let me repeat it. They act like sedatives because everyone in here knows exactly how a sedative makes you feel, right? So first of all, let's look at the fact that MAG is excreted by the kidneys, but it can be lost in other ways too, such as the GI tract. But the primary way to get rid of MAG is through your kidneys. So if your kidneys are messed up, are you going to be able to get rid of the MAG? No. So let's talk about it. Let's talk about hypermagnesemia. Look at it. Okay, look at all the causes. The first cause on your handout is also your first blank, which is renal failure. Okay, renal failure. Now we understand that because if the kidneys aren't working, they aren't getting rid of the magnesium, so it will build up in their blood. The next cause is antacids. Antacids can also contain a lot of MAG. As long as your kidneys are working, they will probably continue to excrete the excess. So anytime you have someone who has a hypermagnesemia problem, they probably started off as some type of kidney trouble. Now, let's look at our signs and symptoms. The first thing you see under your signs and symptoms is flushing and warmth. Now, those are just two weird signs that go along with magnesium. Here's why. Magnesium causes us to vasodilate. It causes us to vasodilate. Remember, that is why your teacher told you that magnesium is given to the PIH lady, because in PIH, your blood pressure is really high. When you give MAG, it will cause the client to vasodilate and make their blood pressure do what? Right, it makes it drop. Also, the magnesium is going to prevent seizures in the PIH lady, because what did we say magnesium works like? A sedative, that's right. Now, look at the box there. Do you see where it says hint? Anytime you get a magnesium or calcium question, think muscles first, and you'll get more questions right than wrong. Think muscles first. Now let's talk about all those signs and symptoms in the middle of your page. So, if I'm sedated, my deep tendon reflexes are going to increase or decrease? Yes, decrease. What's my muscle tone going to be like? Yes, weak and flaccid. Could I have an arrhythmia? Absolutely. If I am sedated, my LOC is going to go down. What's my pulse going to do? It's going to go down as well. What about your respiratory rate? What is it going to do? It's going to go down because what? MAG acts like a Sedative, yes, absolutely. Now, look at the treatment for hypermagnesemia. They might need to be on a ventilator, right? Yeah, it just depends on what their respiratory rate is. If their respiratory rate goes below 12, they are going to need a ventilator. Y'all, if they have a respiratory rate less than 12, they are toxic on mag. Okay, they also might need dialysis because what's not working? The kidneys. In fact, the kidneys may have caused the hypermagnesemia to begin with. Now, I bet your teacher always told you anytime that you have a client with the mag thing going on, what are you supposed to keep available? Calcium gluconate has got to be available, okay? Because calcium gluconate is the antidote for mag toxicity. Now, what does calcium gluconate do? Well, it reverses your respiratory depression and potential arrhythmias caused by your mag toxicity. Now, we know safety precautions because are they sedated? Yes. All right. Let's go back up to the top of the page and look at hypercalcemia. We're going to look at this column on the right side. Now, causes of hypercalcemia. Well, the first thing you see on your handout is hyperparathyroidism, which is too much what? PTH, parathyroid hormone, too much PTH. When your serum calcium level is low, PTH kicks in and pulls calcium from the bone. It pulls calcium from the bone and it puts it in the blood. And this causes your serum calcium levels to go up. Yes, it goes up. So when someone has hyperparathyroidism, we know that's just too much PTH. So do you understand what's happening? Overactive parathyroids make too much PTH, and the PTH causes the body to pull the calcium from the bones and increases the blood or the serum calcium levels. Now the next thing is thiazides, HCTZ. Y'all, it's just a fact that thiazides make us retain calcium. Immobilization also affects our calcium. Now I want you to think about how immobilization affects the bones. Y'all, if we are immobile, will calcium stay in our bones? No, it leaves the bone and goes where? Into the blood, yes. We have to bear weight in order to keep calcium within the bones. So let's look at our signs and symptoms. We end up with brittle bones. Do you understand why they may develop a kidney stone? Because the serum calcium levels are so high and the majority of kidney stones are made of calcium. Remember all those signs and symptoms in the middle of the page? They apply to hypercalcemia as well because calcium acts like a sedative. Yes, a sedative. So now let's look at treatment for hypercalcemia. You need to get your client moving. Get them up and get them moving, okay? We gotta bear weight. That's going to make the calcium leave their blood and return to their bones. Gonna give them some fluids to prevent a what? A kidney stone. Yes, a kidney stone. Fluids help keep the calcium flushed out or prevent stones from getting bigger. Calcium has an inverse relationship with, that's right, phosphorus. So let's look at that. If I am your client and I am hypercalcemic, that means my calcium is really, really, really high. And my phosphorus must be really, really low. Now, steroids decrease our serum calcium, and you'll see why in another lecture. So for now, just know that steroids decrease your serum calcium. What do you think we need to add to their diet? More what? Phosphorus. Yes, add more phosphorus. What foods have phosphorus in them? Well, anything with protein has phosphorus in it. And yes, you are going to initiate safety precautions because you have someone who is sedated. Another thing is, calcitonin decreases serum calcium. Calcitonin decreases your serum calcium. Now, when we give the drug calcitonin, what disease are we treating? Osteoporosis, yes, because calcitonin will drive the calcium back into the bone. Now, let's switch gears a little bit and talk about hypomagnesemia and hypocalcemia. And at the top of this page, I want you to write down, not enough sedative, okay? You got it? All right, let's look at hypomagnesemia first. The first cause that we have listed is diarrhea. We have a lot of mag in our intestines. So if we have a lot of diarrhea, we're going to be losing our mag. But probably the most frequent client we see with hypomagnesemia is the alcoholic, because the alcohol suppresses the release of ADH. So a decrease in ADH means the person will diurese. Alcohol is also a hypertonic solution, which will make you diurese as well. Now tell me, where do we get the majority of our mag that's in our body? Where do we get it from? From what we eat, right? And do alcoholics like to eat? No. What do they like to do? They like to drink. And they like to drink a lot of alcohol. And when you drink, do you retain or diurese? Don't act like you don't know. You know you diurese. So the alcoholic has two things working against them. They're not eating and they're diuresing a lot. So let's look at our signs and symptoms of hypomagnesemia. Remember, they're not sedated. If someone is not sedated, what type of muscle tone are they going to have? Rigid and tight. That's right, rigid and tight. Could they have a seizure? Yes, and that's what I'm scared of. They could have a stridor or laryngospasm because their airway is made of what type of muscle? It's a smooth muscle. A positive Shavastik's. Now, check the Shavastik's on yourself. What did you just do? That's right. You tapped your cheek, okay? And if you have a positive Shavastik sign, the cheek starts to do what? Twitch. Is that normal? No, it shows hyperirritability. Now, a positive Trousseau's is when you pump up the blood pressure cuff, and what does the hand do? It starts to tremor. Again, that's not normal. Could this person have an arrhythmia? Yes, because the heart is definitely a what? It's a muscle. Now, what are going to happen to their deep tendon reflexes? Increase or decrease? They're going to increase, absolutely increase. Now, mind changes. Y'all, that could be anything, couldn't it? On the page before, they were sedated. I told you that their LOC was going to go down. But now this client is waking up. Y'all, they are wired with energy. They may be psychotic. They may be seeing things, or they could be just depressed. Okay, that's when we just say mind changes, because we don't know exactly what their behavior will be like. We can't predict it. Now, swallowing problems can occur because the esophagus is a smooth muscle. And if your client has a swallowing problem, what's the number one concern? Aspiration, that's right. Now, let's look at our treatment for hypomagnesemia. Easy. Give them some mag. But check what function before and during the IV mag. Their kidney function, that's right, their kidney function. So let's practice with a critical thinking exercise. Let's look at the critical thinking exercise in the box on your handout. All right, so you're giving a client IV mag. You're checking their urine output like you should. The urine output is 180 mLs at 10 a.m. and the urine output is 140 mLs at 11 a.m. Are you worried or not worried? Raise your hand if you're worried. I mean it. Raise your hand if you are worried. Now, if you didn't raise your hand, I'm scared, okay? And I'm also glad that you're taking this review, because here's the deal. Our first NCLEX rule says there are no happy NCLEX questions. A test question will not be a test question unless there is something to worry about. So, by the time you finish this review, you are going to be worried sick. So let me ask you again, are you worried? Yes, and you just made your first step towards passing the NCLEX on the first try. But in this critical thinking exercise, everything looked pretty good, right? Yeah, it looked pretty good. The urine output of 180 dropping to 140, it's not that big of a deal, because we don't worry about urine output until it's really, really low. In nursing school, it could drop to 30 mLs per hour before you ever started to worry. But y'all, this is NCLEX, and they want you to be a safe nurse. So since this is NCLEX, you should assume the worst, okay? You always assume the worst. So let's look at our core content hints in this question and assume that something bad is happening. You have a client on IV mag. You are checking their hourly outputs, which have dropped from 180 to 140. I think we know we are worried by now. Some of us may not know what we are worried about, but we're worried. All right. If our client's urine output has dropped from 180 to 140, what might you be worried about? The client may be retaining what? Magnesium. Yes, magnesium. So let's look at our 4 options. Call the primary healthcare provider, decrease the infusion, stop the infusion, or reassess in 15 minutes. Oh, hey guys, there's something I need you to warn you about ahead of time. When you go into the testing center, there's gonna be someone there waiting for you. Okay? In fact, they're just gonna open the door for you and say, welcome, come on into my testing center. And who is it? Dun dun dun, it's Satan, the NCLEX devil. Satan's gonna be in every single test question tempting you. And when the devil is tempting you, is he going to tempt you with something good or something bad? Something good, right? Because we can reject bad easily. It's going to sound really, really good for you, or you wouldn't be tempted by it. That's why all 4 answers are going to look really good. So just like in our question, let's look at our options. If you pick the answer number 4, reassess in 15 minutes. This is what the devil is saying to you. Go on, girl. Okay, I got this. I'm watching her. She's good. She'll be fine. Just 15 more minutes. I got her. So you not being secure in your core content knowledge, you go ahead and leave the room. And then you come back in 15 minutes later, and what's the color of your client? Purple. Okay, y'all, at this point, even the housekeeper knows. Somebody call a code. Patient's not doing good. Okay? Yes, because what had they been retaining for 15 more minutes? Magnesium. And mag acts like a sedative, yes, which made their respiratory rate go down. Absolutely. Y'all, what does the devil want us to do with people? He wants us to hurt people, to kill people, or give them long-term residual damage. Every time you select an answer on NCLEX, you are sending a message to the NCLEX people about the kind of nurse you want to be. Okay? And you only have one chance for the NCLEX lady to make a judgment about you based on the answers you are selecting. If you select this answer, reassess in 15 minutes, the message that you are sending is that you are going to delay care. You never ever want to pick an option that's going to delay care on the NCLEX exam. Now, for those of you who chose the answer number 2, decrease the infusion, this is the message you're sending to the people who write the test. I'm going to kill her slowly, okay? We don't want to do that. That is not the message we want to send to the NCLEX lady. No. If there is even a chance they are retaining mag, you better do what? Yes, answer number 3, you turn off that infusion. You run, go get somebody who knows more than you do. Because they don't want you standing at the bedside with your 2 weeks of vast nursing knowledge trying to figure out a cure. No, they want you to go get someone else who knows more than you do. So you turn off that infusion, of course, and then go get somebody. You, as a brand new nurse, are supposed to say this. Okay, they've given me core content hints. I know I should be worried. I know there's a problem. And when there is a problem on NCLEX, they want me to deal with it. Okay, they want me to deal with it now. You know your client is getting mag, and the urine output has dropped. So you must stop the infusion because their respiratory rate could become suppressed. Now, if you like the answer, call the primary healthcare provider. Now, there are times when this is the only thing you can do, but here's the Hearst Review rule. If there is something you can do to help the problem, do that first before calling the primary healthcare provider. And finally, yes, we're going to place the client on seizure precautions because there is a chance that they might have a seizure. Also, if their mag is low, what do you tell them? Just tell them to eat some mag. Well, where do we find our mag? We have listed for you spinach, flaxseed, cucumbers. See all those listed in your little box? Now, you have all heard there are a lot of management and delegation questions on the test, right? All right, so let's practice this. Let's look at your box on your handout. There are 2 nursing assistants down the hall, and they are both about to ambulate someone. The first nursing assistant is about to ambulate someone with a history of severe grand mal seizures. The other is going to ambulate someone who is 8 hours post-heart cath. In which one of those should you, as the nurse, intervene? Okay, which one? All right, did you say the one that is 8 hours post-heart cath? Yes, because what are we worried about? We're worried about hemorrhaging. Yes, we're worried about hemorrhage. Let me clarify something, because I know what some of you are thinking. But Megan, some clients go home right after their procedures. Okay, yes, they do. You are right. But the point is, can they still hemorrhage and bleed to death? Yes, and that is what we are worried about. Now, the grand mal seizure people, I know what y'all are thinking. Well, Megan, what if they just get out in the hall and they just have a seizure? People with a history of grand mal seizures can walk, can't they? Yeah, so if they start having a seizure, what are we supposed to do? Break the fall, try to catch them. Don't let them just fall on the floor. Protect their head. Turn them to the side and start taking notes, because the first thing the physician is going to ask you is, what did it look like? You don't want to be like, oh, doc, you should have been there. It was so bad. They just hit the floor and went boom. Okay, no, okay? Again, you're going to pick the heart cath, okay? Are you going to pick the heart cath or the grand mal seizure answer? The heart cath is the right answer. All right. Now, what are you supposed to do when your client starts complaining of flushing and sweating when you start IV mag? You stop it if you want to get a license. Here's the deal. Those are normal signs and symptoms when giving someone IV mag, aren't they? Yes, they are. But could they be a sign of worse things to come? Sure, they could. That's why we are going to assume the worst. Remember, test questions plus NCLEX equals we got a problem, okay? We may not know what the problem is, but there is a problem. Now, if you take that sentence to an experienced labor and delivery nurse, they're going to say, everybody you start IV mag on is going to be flushed and sweating. Well, hey, they've already passed their boards, right? All right, let's go back to the top of the page to hypocalcemia. Some causes are due to hypoparathyroidism, radical neck, and thyroidectomy. Now, out beside all 3 of those things, I want you to write this down. Not enough PTH. Not enough PTH. If we do not have enough PTH, the serum calcium will go down. So with the thyroidectomy or radical neck dissection, the physician can accidentally take out a couple of your parathyroids. If they accidentally take out a couple of your parathyroids, you're not going to be making as much PTH. So naturally, your serum calcium levels are going to go down. Now, all those signs and symptoms in the middle of the page that we've already gone over with hypomagnesemia, they apply here as well. You can look at them for hypocalcemia as well. So let's look at our treatment for hypocalcemia. We have vitamin D to help utilize the calcium. Then we have sevelamer and calcium acetate. And when you bind the phosphorus, the serum phosphorus will go down, which makes the serum calcium levels go up. Yes. Now, the next is calcium. Let's take a second and listen to Aunt Marlene and see what she has to say.
So, let's do a critical thinking exercise to make this clearer to you. You're giving IV calcium, and of course you have them on a heart monitor. Their PQRST is looking really good. So, you give a little more IV calcium. Now remember, I said it would slow them down a little bit and widen what? Yes, the QRS complex. Now, do you think they want you to just look at that and say, oh look, it did widen, just like the book said. That's neat. Let's give him some more. Ooh, that's really wide. Now, you didn't have to take the EKG class to know this is not good. What did you just throw this person into? Asystole. So now what are you going to do? CPR.
All right, let's talk about sodium a little bit now. Your sodium level in your blood is totally dependent upon how much water you have in your body. So circle water on your handout. Y'all, this is the only electrolyte that cares about water. Now, your teacher told you sodium follows water. But we've already said that there are times where they don't follow one another. Remember SiADH and Di? Also hyper and hyponatremia as well. If they followed each other all the time, you would never have patients with hyper or hyponatremia. Okay? Now, hypernatremia is the exact same thing as dehydration. It's too much sodium and not enough water. Okay? Too much sodium and not enough water. So let's look at its causes. And the first cause is hyperventilation. Well, why? Because every time you exhale, what are you losing? Water. And what did your teacher call that? Insensible fluid loss. Now, the next thing you have on your handout is heat stroke and diabetes insipidus. Now, we didn't put the obvious things on there like vomiting and diarrhea because everyone knows those things will cause you to have dehydration. Now, everyone in here has had probably some degree of dehydration sometime within their life. That's why you've had the dry mouth. Maybe you were thirsty because you needed water. Now, you probably didn't have the swollen tongue. That's the weird one you only see with hypernatremia. Neurochanges. Now, that's the biggie. In fact, let's write it at the top of your page. Sodium. Think neurochanges. Sodium. Think neurochanges. Our brain doesn't like it when our sodium is messed up. It doesn't matter if it's hyper or hyponatremia. A person can die and nothing else be wrong with them other than their sodium is messed up. But when you and I look at electrolytes in the hospital, people don't look at their sodium levels often. What do we look at? Their potassium, that's right. But don't forget about their sodium too. So for treatment, restrict their sodium. That makes sense. Okay, if they're hypernatremic, we want to restrict their sodium. We could dilute the client with some IV fluids because diluting makes the serum sodium levels go down. It makes the sodium levels go down. If I have vomited 10 times, y'all, am I going to be dehydrated? Yes, they're going to start IV fluids on me to dilute my blood. The more they dilute my blood, the lower my serum sodium levels are going to go. Now, we want to be doing daily weights and INOs as well. If your client has a sodium problem, they also have a fluid problem. So don't forget to continue to monitor their lab work. Now, feeding tube clients tend to become dehydrated, and it says on the can of Ensure, the feeding, total nutrition. It has everything needed to live, the protein, the electrolytes, the vitamins, the minerals, everything but the water, yes. So let's pretend you have some with the tube feeding. And when you have someone with the tube feeding, you better be checking their sodium levels every day. Now tell me, what's the normal sodium level? 135 to 145, that's right. So today, that tube feeding client's sodium level is 135. Tomorrow, it's 137. And the next day, it's 139. All of these numbers are in normal range, but what do you notice? Every day they're going up just a little bit. So to prevent dehydration, what should we do? Ask the physician if we can give them some more water with their tube feeding. Don't wait until something is out of range to do something. Do something ahead of time. All right, let's go back up to hyponatremia. This person is diluted. You have too much water, not enough sodium. So it's causes, because you're drinking too much water for fluid replacement. When the client has been vomiting or sweating, this only replaces the water and it dilutes the blood. When you vomit or sweat a lot, you've lost a lot of fluid and electrolytes. And if you drink just plain old water, are you replacing everything you've lost? No, so you're gonna become diluted. What should you be drinking? Gatorade, yes, to replace the electrolytes. Now next is psychogenic polydipsia. With this disorder, the client just loves to drink what? Water, yes. So remember, this is the psych client that just loves to stay at the water fountain all day long. They will drink so much water so fast that it affects their brain, and that's what they like about it. We've seen people in the hospital getting D5W, sugar and water, yes. Could they become diluted? Sure. Also, clients with SIADH will become diluted because they are retaining water. Now tell me, what organ doesn't like it when the sodium levels are messed up? The brain. Yes, the brain. So signs and symptoms. You may see headache, seizure, coma. Now for treatment. The client needs what? Sodium. That's right. The client needs sodium. What do they not need? Water. They do not need any more water. Now, let's talk about that last statement for a second. If you have a client with neuro changes because they are so diluted, they need a big old dose of sodium, don't they? Yes, that's right. That's when you're going to see the physician order that hypertonic saline. Anytime you see the words hypertonic, you should be thinking packed with particles. Yes, like 3% or 5% normal saline. Your next job is to figure out what the particle is. If it's a hypertonic saline, then it's going to be sodium. If you give someone a large amount of sodium into their vascular space, it can act like a sponge. So what are we going to be worried about then? That sodium will begin pulling fluid into the what? Into the vascular space, yes. So this person is at risk for going into fluid volume excess, that's right. That's why 3% and 5% normal saline is a very dangerous solution. Some hospitals with this solution, it's only given in the ICU setting, or you may have a very specific protocol to follow if you are administering this solution to a client on the floor. Also, remember, anytime you're giving large doses of sodium IV, give it slowly because the brain can't handle this huge shift in the serum sodium. Let's say you have a client who's a marathon runner. That's a little crazy, huh? But they're preparing for their race. Your client drinks 1 liter of water about 15 minutes before the race. They're trying to just pre-hydrate. Then at each stopping point, they drink a little more water. So they're running and sweating and drinking more water. What do you think this is doing to the runner's sodium level? Will it be high or will it be low? Okay, we had this person who is sweating and running a lot, and they're only drinking water, so their sodium levels will be low. Yes, because you have someone who is running and sweating and replacing fluids with water only, and this is diluting the blood. Remember, we said dilution makes numbers go down. That's right. And the only 3 numbers we are referring to here are specific gravity, sodium, and hematocrit. Now, let's say we have little old Granny. Isn't she so cute? Oh, she's just cute. Now, she has Alzheimer's. Okay, well, Granny lives by herself, and sometimes she forgets to drink anything all day. So, will she be hyper or hyponatremic? What do you think? Is Granny dehydrated? Yes, so her sodium levels will be high. Yes, they will be high. Will she be thirsty? Yeah, she could be. What about hypotensive and weak? Yes. Could this lead to renal failure? Yes, because there are no volume there to perfuse the kidneys. All right, let's look at the next thing on our handout, potassium. Now, the potassium is excreted by the kidneys. If the kidneys aren't working well, the serum potassium level is going to go up or going to go down? Absolutely, yes, it's going to go up. So, hyperkalemia. Let's look at the causes. Kidney trouble. We understand that. Spironolactone can cause hyperkalemia because spironolactone makes the client retain what? Yes, potassium. It makes them retain potassium. So let's look at the signs and symptoms. Hyperkalemia begins with muscle twitching, then proceeds to muscle weakness, then flaccid paralysis. Could your client develop a life-threatening arrhythmia? Yes. So if you had a question that asks, which one takes priority, which one would you pick? The life-threatening arrhythmia or the muscle weakness? Absolutely, you're going to pick the life-threatening arrhythmia because that's the one that is going to kill you. So on NCLEX, you could get a lot of questions that use the word priority. When you see the word priority, it changes the way you have to answer the question. And one way to answer priority question is to pick the killer answer. Muscle weakness won't kill you, but a life-threatening arrhythmia will. Now, on to treatment. These are emergency measures. First of all, dialysis, because obviously the kidneys aren't working. Calcium gluconate to decrease arrhythmias. Calcium gluconate will be given to decrease arrhythmias. Glucose and insulin can also be given. Insulin carries glucose and potassium into the cell. So glucose and potassium into the cell. Therefore, the serum potassium drops. So anytime you give IV insulin, there are two hypos we got to be worried about. Hypokalemia and hypoglycemia. Yes, hypokalemia and hypoglycemia. The next thing on your handout is K-Exolate. Circle the K in K-Exolate. The only time you ever give K-Exolate is when you have someone who is already hyperkalemic. Anytime you see that drug, you automatically know your patient is hyperkalemic. So, how does it work? Well, it exchanges sodium for potassium in the GI tract. So let's think about that. The client has a very high potassium. So when you give them K-Exolate, you're exchanging potassium ions for sodium ions in their GI tract. So you're increasing their sodium levels, which was sneaky, because what are you doing to their potassium levels? You're bringing it down. So what type of relationship does sodium and potassium have? It's an inverse relationship. Now, if you are increasing their sodium, could you cause them to become dehydrated? Yes. What could you do to offset this dehydration here? That's right, push fluids. Now I want y'all to go back up to the top of your handout and let's look at the opposite side, hypokalemia. The first thing is causes, like vomiting, NG suction, and we have a lot of potassium in our stomach. So anytime someone has vomited or has an NG tube hooked up to suction, they're going to be losing potassium. Diuretics, now I know you already understand this one, and anyone not eating will not be getting potassium. Okay, signs and symptoms. The signs and symptoms of hypokalemia are first muscle cramps, then muscle weakness, and what's the last one? Arrhythmias. That's right, it's arrhythmias. Now for treatment, easy. Let's give them some potassium. Okay, let's just give them some potassium. Give them some spironolactone so they will do what? Retain some potassium. That's right, retain potassium. Tell them to eat more potassium. Okay, last thing. Yay! Miscellaneous information. What is the major problem with PO potassium? GI upset. Yes, GI upset. So give it with food. Okay, make sure to give the potassium with food. Now I want you to put a big old star by the next sentence. Assess urine output before and during IV potassium. If the urine output drops during this infusion, what are they retaining? Potassium, because potassium is excreted by the kidneys. So that could kill your client, right? Yes. Be certain that your client has good urine output if you're giving them IV potassium. Always put IV potassium on a pump. It must always go on a pump. And make sure to mix it really well. Okay, move that bag around. Make sure it's all good and mixed. Never give IV potassium as a push. It will kill you. It must be diluted in something. The physician needs to tell you what kind of fluid and how much fluid that he wants. Is it going to burn during the infusion? Yes, especially if it's a strong concentration. For instance, if you had 40 MEQs of KCl and 100 mLs of normal saline given over 4 hours, that's going to burn. Watch the IV site because potassium eats up those peripheral veins. Yes, it eats up those peripheral veins. All right, guys, that's it for fluid and electrolytes. Congratulations on finishing our first topic.